Hello, my name is Neil Dilworth, and this module is going to be on the indications for investigating neck and low back pain. And we'll get started here. So the objectives are to understand when we're recommending an investigation of neck or low back pain, what tests to order based on either red flags or worsening or failure to improve symptoms at follow-up, and tests that may be in fact indicated at follow-up but not acutely. So in terms of an investigation overview, blood work is one of the things we'll talk about for both neck and back pain. Kind of combination of infection, cancer, and inflammatory conditions are kind of the things that we'll be looking at from a blood work perspective. So the basics would be a CBC, an ESR, and a CRP. And then specifically looking at some specific inflammatory or autoimmune markers as necessary. There may be some essentially tumor markers that you may want to add on based on your index of suspicion. And then when we talk about imaging, really we're talking about x-rays, CTs, and MRI scans. Not a lot of evidence for the use of bone scan. But for non-specific symptoms and where you're concerned, it may be a worthwhile adjunct, even though I don't mention it here. So for x-rays, this is something that for a trauma history, where you're concerned either about fractures or instability, that's definitely worthwhile considering a cervical spine series plus or minus flexion extension views. And then the other one is for progressing symptoms or failure to improve and follow up. Taking a look for spondylosis conditions. So these are kind of your degenerative or osteoarthritic changes that can occur in the spine over time. CT scans obviously will give a lot more information than X-ray. Once again, very helpful for looking at both occult fractures that may not be seen on X-ray, but also bone lesions that can occur with metastatic bone disease. MRI imaging is really more important when it comes to nerve root or spinal cord compression conditions. It will also take a look and give good information with respect to bone lesions, osteomyelitis, and epidural abscesses, as well as infections relating to the disc, and as well as disc pathologies. And then finally, with respect to EMG and nerve conduction studies, these are actually used fairly commonly as a workup, just to be aware that there's about 50 to 70% sensitivity for picking up nerve root dysfunction. So false negatives are unfortunately common. And so not to discount somebody's symptoms in clinical examination, regardless of a negative EMG and nerve conduction study. So a lot of this imaging is going to be driven by red flags. So that's from an acute perspective, or also if these red flags come up at a follow-up appointment for either a follow-up for acute or neck or back pain, low back pain. So any kind of progressive neurological deficit. So it doesn't necessarily have to be bilateral, but it's essentially progressive weakness, progressive sensory loss, especially heat or temperature. This is something that is going to warrant essentially further investigation, specifically with MRI. History of trauma, obviously any kind of higher risk motor vehicle accident, fall from a height, or from a sports perspective, any kind of significant axial loading, like a spearing injury. You're going to want to essentially clear the cervical spine with bare minimum to considering cervical spine x-rays, but maybe also considering a CT spine. If there's any kind of history of fever, meningeal signs, this is something where you might warrant, obviously, referral to an emergency department. This is something whereby further investigation would be warranted for a non-musculoskeletal type pain. It can be anything from essentially referred symptoms from meningitis or a subarachnoid hemorrhage, or something along the lines of like a vertebral artery or carotid artery dissection. So these are things to kind of keep in mind when you're screening these patients, either in the initial assessment or follow-up, history of any kind of cancer or B symptoms, weight loss, night sweats, increasing pain at night, or kind of a very, very severe acute pain in the absence of any kind of injury or prior neck issues. Those are all kind of concerning features. And then obviously a positive inflammatory history is something that would warrant some blood work plus or minus some imaging. And then, like we mentioned in the core neck tool, any kind of atypical, non-specific symptoms or sometimes specific symptoms, whether we're talking about lightheadedness associated with the neck pain, palpitations, chest pain, shortness of breath. These are things that are outside the realm of what would typically be seen in the musculoskeletal neck pain and would warrant further investigation or referral. So when we take a look at either the core neck or back from an assessment perspective, when these pop up on the history, these are things that would warrant further investigation or at the very least a referral to see somebody for further assessment. So we're talking about the limb dominant pain that's constant, any kind of extra musculoskeletal symptoms, so cardiac, neurological symptoms, a history of trauma, and inflammatory again. It's kind of what we talked about before in terms of what imaging to consider based on that positive history. So trauma, obviously X-ray and CT spine, C-spine, neurological, MRI plus or minus the EMG or nerve conduction study. Sometimes the specialists want to see that testing, but it's not always necessary. And then inflammatory blood work, plus or minus X-ray, plus or minus MRI. And then obviously with the infectious, you want to do a combination of both blood tests as well as imaging. Those patients may also be warranted for further referral before you work them up, such as to an emergency department. So now what we're going to do is we're going to go through cases of each one. So the first one we're going to take a look at, before we get to that. When we get to a follow-up appointment with patients, so these are non-red flag situations. This is kind of the common thing that you're going to see in a primary care perspective. These are the non-red flag things that are going to warrant further investigation. So patients that are having constant radicular pain, but it's not improving. You've tried them on a neuropathic medication. They've tried modifying their activity and positions, and it's still not improving, or it's getting worse. That's an indication for imaging, specifically with MRI. Or obviously if they're developing a motor weakness, or at follow-up, you're starting to notice essentially muscle atrophy or motor weakness on testing that wasn't there previously. This should also prompt you to essentially initiate some MRI imaging. So now let's take a look at some cases. So first case, and I'm going to show you the imaging first, and then I'm going to give you the history just to show you how well the the core neck and back tools work in terms of these situations. So here is a C-spine X-ray. You can see on the imaging that there is some soft tissue material involved. When we take a look at the cervical spine, the proximal cervical spine looks to be intact and in line. And then when we get down to C4 and C5, you can see an anterior listhesis. So this is an unstable fracture dislocation. The cervical spine is obviously a very significant injury, and this requires acute and emergent surgery. Now, here's the history of the patient. So this is a 32-year-old water skier who essentially landed on his head and neck from a height of about 30 feet on the water, was extracted with C-spine immobilization and then taken directly to local emergency department. But once again, there's a significant history of trauma, warrants imaging, and even on X-ray you can see essentially a significant finding. Now this is essentially a MRI. You see on the left you see is a sagittal image, and on the right you can see the associated axial imaging. A little bit difficult to see on the axial imaging, but on the left, if we start from the top and we go from C1, C2, C3, C4, C5, C6, in between C6 and C7 you can see a large disc protrusion pushing the back onto the spinal cord. And then when we take a look at the image to the right, just left of that yellow line, so this is, in terms of from an imaging perspective, this is actually corresponding, even though it's on the left of the image, it's corresponding to the right of the patient. You see a little kind of circle-like image at gray. That's actually the disc pushing over the intervertebral foramen on the right side at the C6-7 level. So how did we come across getting to imaging of this patient? This is a patient who presented with acute shoulder-dominant pain, this shoulder pain essentially progressed despite having a normal range of motion of the shoulder and despite having maximal neuropathic treatment and also a short course of oral corticosteroids. And in follow-up, as a result of no benefit with essentially trying to return back to activities with modifications and conservative treatment, an MRI was arranged which showed this essentially large disc protrusion compressing the area, and he was referred for neurosurgical consultation and essentially subsequently ended up having an operation for decompression. Inflammatory, so this is a lateral C-spine X-ray. One of the things you'll see here is that there's a loss of the normal lordotic curvature of the cervical spine, and then you can see essentially bony bridging between the vertebral bodies. So that loss of lordosis of the straightening of the cervical spine with those are in keeping with a Bamboo spine. This is something that you'll see in ankylosing spondylitis. And how did we get to doing this imaging? Once again, this is a patient who actually had a known history of inflammatory arthritis, specifically ankylosing spondylitis, who presented with essentially a 1.5 month of progressive neck stiffness, which led to the cervical spine X-rays, which we can see in the imaging here. So once again, positive red flags, and this led to the imaging. Finally, this is a case report from Journal of Neurosurgery. This is essentially a sagittal MRI, and what we will see here is if we take a look at the L5 vertebrae, just posterior to it, you can see essentially a round protrusion pushing back on the vertebral foramen, and that is in fact an epidural abscess. And how did we get to this imaging? So the history here was a 74-year-old gentleman with severe acute low back pain with bilateral progressive weakness and with a recent history of dental work having been done. And so once again, red flags are present, and this led to essentially further imaging. So in summary, imaging for the most part can be reserved for cases of non-red flag neck pain or back pain that persist greater than 3 months despite attempts to return activity. If the symptoms are progressing, you may consider doing that sooner. But if they're not worsening and there are no red flags or neurological symptoms, most cases are unlikely to require any imaging or further investigations. For red flags, obviously, as we saw in those cases, use appropriate investigations based on the type of red flag present, and also be aware of the false negatives associated with nerve conduction and EMG testing, and not to allow that to distract you from a potential diagnosis. Here's some references. Thank you very much.